हेलो गुड मॉर्निंग। आज हम बात करेंगे पेरिफेरल ब्लड एग्जामिनेशन की। दिस इज़ द बेसिक evaluation of patient generally starts with the complete blood count, that is CBC. Though the CBC is the basic test, it yields the plethora of information. Not only gives the total cell count and hemoglobin, red cell indices, thus the types of anemia. The process of peripheral smear evaluation, it starts from the preparation of a smear from the peripheral blood. An ideal peripheral smear has a three part, that is the head and then body and tail. The smear is the best evaluated in the junction of body and the tail. The Romanowski stain used for the staining, and the stains used vary from Leishman to Wright's combination, such as the Wright Giemsa stain, and sometimes Jenner Giemsa and May Granwald Giemsa. However, the correct evaluation of the smear optimal staining is the of granularity. Wright Giemsa and NGG are the best, were recommended by the WHO. Peripheral smear examination is indispensable to determine the type and etiology of the anemia. Microcytic hypochromic red cell indices coupled with the microcytic hypochromic red cell picture and red cell and isocytosis indicative of iron deficiency anemia in the presence of thalassemic red cell indices. Evaluate the red cell count with marginally reduced hemoglobin and microcytic hypochromic red cells with the lack of red cell and isocytosis. A peripheral smear showing microcytosis, particularly diagnosis of the thalassemia. Thalassemia further confirmed by the hemoglobin HPLC in our country, sometimes even with a normal MCV. The patient may actually have nutritional anemia, or there may be dual deficiency of iron and B12 or folate, which cause red cell and isocytosis, but due to the presence of both micro and macrocytosis, the MCV may be entirely normal. In the presence of macrocytic red cell indices, the peripheral smears can lead to the confirmatory for the diagnosis of megaloblastic anemia, making a bone marrow examination completely unnecessary. For the diagnosis, the presence of hypersegmented neutrophils, macrophagocytes, or with or without the presence of megaloblastic and nucleated red cells in the circulation indicates a vitamin B12 and folate deficiency. A particular attention should give to the presence of hypochromia, as patients may have a concomitant iron deficiency, and the best response are achieved only when the iron and B12 and folate are the supplement together. As many hemolytic anemia, such as sickle cell anemia, hereditary spherocytosis, may develop an acute deficiency of forates, and repeat smear evaluation after the treatment. Folate deficiency key diagnosis of the underlying hemolytic anemia. Peripheral smear evaluation absolutely mandatory when the investigation suspected hemolytic anemia. The presence of spherocytosis, microspherocytosis, is important route for the diagnosis of hereditary spherocytosis. Hereditary spherocytosis, as well as the family history. A simple smear evaluation adequate for the diagnosis of this condition. The spherocytes may be additionally seen in autoimmune hemolytic anemia, which the smear may be composed of primarily polychromatophilic cells and spherocytes. If there is a brisk hemolytic anemia, for the presence of red cell agglutinates also. These of the red cell count cause the characteristic of red cell indices, and red cell count hematocrit and that are not correlate with the hemoglobin and an extraordinarily high MCV, MCH, and MCHC. The diagnosis of sickle cell anemia is easy when the classical sickle cell seen and the marked red cell anisocytosis with the microcytosis, hypochromic cells, irregularly contracted cells, and the outpouring of nucleated cells in pathognomic of thalassemia major. Patients of sickle cell anemia and post-splenectomy thalassemia intermedia may in the addition show the presence of alveolar bodies and sometimes white cells, blister cells, and the characteristics of that are the characteristic of G6PD deficiency. Some patients may have a cystocytosis accompanied with the thrombocytopenia, may have evidence of microangiopathic hemolytic anemia. Such patient such patients should be investigated the disseminated intravascular coagulation. If the coagulation tests are normal, may have a thrombotic thrombocytopenic purpura or a hemolytic uremic syndrome, and accurate and prompt smear evaluation. Such a case may be life-saving and clinically rewarding. In all the cases of persistence anemia, especially in elderly whom the apparent cause is not seen, it is the addition other features such as a nuclear hyposegmentation. If these findings are present, the patient should be further investigated to exclude the confirmed possibility of myelodysplastic syndrome. In case of prominent teardrop cells and leukoerythroblastic reactions, a simple peripheral blood smear gives the clue towards the marrow infiltrated disorder or marrow fibrosis. Sometimes anemia may be the only presenting features of acute leukemia. The conclusion is peripheral smear is extremely important for the determination cause of anemia, and it is fruitful in the majority of the patient. In addition to gives the clues towards the further evaluation